The result I'm presenting here has been recently published on journal Shoulder above from the work of the Sigascott group of Italy. So, as we see in the previous presentation, the patient selection is a still debated topic because we know well that there are a lot of risk factors to be considered, and there are several procedures that we have to consider for the best surgical option. As you see in the slide, the ISIS score is the most used classification to make the proper surgical choice. And the cutoff of 3 points is recommended for a letter J or Bombock procedure. In this flowchart, you see the current approach for chronic shoulder dislocation when glenoid bone loss with engaging il sacs, procedure like bone grafting, arthrolatergy, letter J procedure are strongly recommended. In patients with younger age, hyperlaxity or poor quality tissue now are available 2 Bancar Plus procedure, and now 3, like remplissage or arthroscopic subscapularis augmentation. The use of the letter J demonstrated the lowest in the literature, the lowest recurrence rate, but there is a concern, there is a still concern about the major complication that may occur. So now I present Bancar Plus procedure and remplissage. You see here a short movie about the ASA procedure. You see on the lower the Bancar repair, and in the upper the tenodesis of a subscapularis tendon. Obviously, I use this procedure even to revise some failure in such case of remplissage. You see the soft tissue anteriorly, the poor quality soft tissue. Here the heel sacs lesion, the refreshing of the anterior portion of the capsule with the removing of the scar tissue and the stitches. And you see the augmentation and the partial tenodesis of the upper third of the subscap. So the purpose of the present study was to compare the clinical outcomes of the most used surgical techniques in patients with recurrent shoulder dislocation with a glenoid bone loss more than 50% and an ISIS score more than 3. The pool patients was more than 200 people. The 4 surgical techniques compared were Bancar plus ASA, Bancar plus remplissage, arthrolatergy, and upper-latergy. Here you see the inclusion criteria and the exclusion criteria. The hyperlaxity patient was evaluated with a Kudan-Walsh test, and the Pico area method was used to assess the glenoid bone loss. And the individual characteristics are considered too. The raw score and the Western Ontario WOSI score were used for the clinical outcome assessment. Here you see, it's not easy to see, but there are all the demographic data. Here you see that the raw score are similar for both techniques, remplissage, ASA, latergy, and arthrolatergy. Here, the same for the WOSI score. In the score, we didn't find a statistical difference between the results of each techniques. We noted a difference, statistical difference in the external rotation loss for the repressage procedure. Here you see the comparison of the ISI score for the 4 technique. And there is, should be noted, should be reported that between 4 and 6 points of the ISI score, all the technique had similar results. You see that here that the ladder J had the lowest recurrence rate, but on the contrary, the highest complication raised. You see the same results for row score and WOSI score, even in external rotation. So the take-home message I would say is that the bunker plus procedure nowadays are effective for restoring joint stability with clinical outcomes similar to the ladder J procedure, and coracoid transfer or bone augmentation procedure should be considered in patients with ISI score more than 6 and GBL more than 15%. Thank you for attention.